Playing around, yeah, very good.
We're live.
Are we? Oh,
yes,
okay. Then this may be a good idea to start the session. Hello and a very warm welcome to the joint session of the European Society of Anesthesiology and Intensive Care and the European Resuscitation Council. Maria Jozescu and I will be chairing the session, and we are very pleased to introduce three speakers that are with us today. And we will focus on the topic, as you would have thought, cardiac arrest, and look at the things that relate us to anesthesia as well. What are the key topics during the few years? I mean, we found out that obviously early resuscitation as soon as possible has probably the most important effect on outcome. And Bibiana Medelman from Greifswald University, a researcher and an excellent clinician, is going to tell us about the effect of laypersons, strengthening the chain of survival by empowering laypersons. Bibiana, the floor is yours.
Thank you so much for your kind introduction and the possibility to talk here. I feel really honored and I appreciate being with you here. So I'd like to talk about strengthening the chain of survival by empowering medical laypersons. To start off, I have no conflict of interest. So if we talk about the chain of survival, probably what pops up in our mind is this picture with four links that are together to build a chain. It's the early recognition and call for help to prevent a cardiac arrest. It's the early CPR to buy time. It's the early defibrillation to restart the heart. And it's post-resuscitation care to restore the quality of life. So one might argue whether that's 4 or 6 different parts that form together a chain and whether you should rename it or not, but probably it gets down to those 4 things. But Deacon found out that not all links are equal. Maybe there are some links that are more important than the other ones, because as you probably all know, although many people enter the first part of the chain of survival, it's the early recognition and call for help, not all will get to the point of post-resuscitation care. So if we want everybody to have a good chance at survival, we have to strengthen the first and the second part. But we can't do it on our own, especially in out-of-hospital cardiac arrest. We have to rely on the population. We have to teach them how to help us get through the chain of survival. So especially the recognition and call for help has to be done by the medical laypersons, but also the start of CPR. You probably read this article about the big 5 in resuscitation. So the idea is maybe the most impact on survival will not be the discussion whether you should give or administer adrenaline after 4 or 5 or 6 minutes, or whether you should skip it at all. But maybe the most impact might be done by increasing lay resuscitation rates and telephone CPR. It is estimated that if we increase lay resuscitation rates, we could triple the survival rates. And if we implement telephone CPR or broaden it, we will double the impact on survival. But we are not there yet. In the Eureka 2 study, we could show that on average, 58% of the European country, the bystander CPR rates in Europe are around 58%. However, there's a huge range between 13% and 82%. So while some countries have figured out how to involve bystanders, how to involve the medical laypersons, others still struggle to do so. So that's why there are lots of campaigns to involve the medical laypersons. And I'm looking forward to seeing the results from Eureka 3. Eureka 3 will start in autumn this year. So let's see what the results of this one will be. last year, when the guidelines came out, there was the first time that they added a chapter on system saving lives. So the idea is it's not just one thing that will change the impact on survival, it's the whole system. So therefore, we have to do different parts, and together a system will save the life. And the first of the 5 top messages of the System Saving Lives Guideline chapter is raise awareness about CPR and defibrillation. So we have to train as many citizens as possible, and we have to engage with the World Restart a Heart Day. However, it might be difficult to get the people to be interested in a resuscitation course. It might be difficult for them to travel all the way to a university simulation center, or it might just not be on their mind to do a course like that. So what we really have to do is, apart from doing this high fidelity simulation courses, we also have to go to the people, get out to them, to go where they are. So we have to go to the marketplaces, or even better, to go to some fairs, to some festivals, things where people are enjoying themselves, going for a walk, and have time to do different things, try out new things. So maybe we have to do more of that between all the food stalls and the things where you can try out new things. We have to have a booth where we can train people in resuscitation. They can do it, we can do that in a pretty easy way, and it just takes 10 or 15 minutes of their time. So we can teach them how to do a compression, and we can also teach them about the importance of recognizing a cardiac arrest. So these things come together with the World Restart a Heart Day. As referred in the opening ceremony just a few hours ago, the World Restart a Heart Day is on the 16th of October, and it's a World Restart a Heart Day since 2018. Before that, it was the European Restart a Heart Day, and now it's all over the world. All the Resuscitation Council take part. So while the campaign doesn't have to be on the 16th of October exactly, it will still be involved in this concept. And does it work? Yes, it works. We can teach a lot of people at the same time. And in 2018, the first year it was the World Restart a Heart Day, more than 675,000 people were trained in CPR worldwide. And even more were reached via social media. That was 12.7 million people. So why not every one of this 12.7 million people really did a compression or really trained with 100 beats per minute? They each got in contact with the concept of cardiac arrest, and they thought about it, and maybe they were motivated to go to a next course. And the year afterwards, these numbers could be even more increased. 5.4 million people were trained in CPR worldwide, and more than 206 million people were reached via social media. So this system does work. We can really reach the people. And another really important campaign is Kids Save Lives. The idea is that every child over the age of 12 years should get 2 hours of CPR training annually in all schools worldwide. And it was proven many times that children can learn how to do a resuscitation. They can do chest compressions in an effective way, starting from, I'd say, 8 or 10 years. And even if they can't compress correctly, they can motivate the adults to come there and do the compressions. And it's more often than you think that children are the ones who initiate the start of compressions and initiate the chain of survival. There are many stories that can tell this. So one of the important things is that we have to keep it clear and simple. So the BLS chapter stick with the phrasing of unresponsive with absent or abnormal breathing to not confuse any laypersons. They stick with the same phrasing. However, we all know that abnormal breathing is hard to detect. So if there's no breathing, the probability of bystander CPR is pretty high compared to agonal or any other form of breathing. And interestingly, the same is true if the person is unconscious compared to consciousness. So witnessing a cardiac arrest, one would say that is a pretty easy thing for a bystander to detect, oh, wow, he's doing bad, we have to do something. However, it might be difficult for them to grasp that the person who was talking just a few minutes ago is really in a cardiac arrest. So while they would detect it's in a medical emergency, many have struggled to really detect that this is a cardiac arrest and they have to start compressions. So we have to train our dispatchers to also think about this part. So what can we do else? We have apps, smartphone apps that give real-time instructions. So we were wondering whether these real-time instructions are guideline compliant. And in a huge process, we searched in the Google App Store and Apple App Store to see what apps are available at the moment. And then we checked whether they are guideline compliant. And while all apps stated on the start of chest compressions, not all focused on the topic to consider abnormal or agonal breathing. So what we have to do is we don't only have to tell our dispatchers to think about agonal breathing, but we have to find a way for all the information that could get to laypersons to be correct. So these apps have to be guideline compliant, and we have to find a way how to ensure that. This was proven by another study group who saw exactly the same, that apps are guideline conform in some points and in others not. And then we chose the app that was guideline compliant and had the highest usability and wanted to see whether this would do a benefit or a harm in a simulation study. And we could show that using an app with real-time instructions led to better compression depths, better chest compression frequency, but it led to longer times to check for breathing, call for help, and to initiate chest compressions. So we say it's of an ambiguous benefit. So while in the overall, the compression depth is better, it takes a longer time. And then there are some studies getting to the topic that witnessing cardiac arrest is a pretty emotional thing for bystanders. So there's more research coming up how to deal with it, because people suffer signs of pathological, psychological processing, even if it's not their own relatives that had the cardiac arrest, but just somebody they saw collapsing in a park. So it's a total stranger, but still they have problems processing it. That's the bad side. But the good side is that if the bystander performed CPR, there were a higher rate of no signs of psychological distress due to OCA. So the good thing is, if we teach the medical laypersons to perform CPR, it would not only benefit the person having the cardiac arrest, but it will also benefit the bystander, because then he is having more possibility to cope with these distressful moments. So let me get back to my topic, and I would like to state, we have to empower medical laypersons to strengthen the chain of survival. So thank you very much. This is a picture of Greifswald, where we're doing a huge cardiac arrest event. Thank you so much.
Sorry, I just silenced my microphone. Thank you so much, Viviana. What we're going to do is we will be having the discussion at the end of this session, and I would like to hand over to Maria to introduce the next speaker. Again, thank you very much, Viviana, for your great presentation.
We cannot hear you. The microphone is not on.
Oh, that's a bit of a shame.
Sorry about that. I'm happy to introduce our next speaker, who is going to talk about management of cardiac arrest in pregnancy. Professor Caroline Weniger, who is the Director of Obstetrics Anesthesia in the Department of Anesthesia and Critical Care at the Tel Aviv Sourasky Medical Center. And also she's the chair of the Obstetric Anesthesiology Subcommittee of the ESAIC. Dr. and Professor Weniger, the stage is yours. Happy to hear your talk.
Thank you so much for ESAIC for putting together this panel at this fantastic meeting. I'm just sorry I can't join in person, and I'm very grateful to the organizers for the opportunity to speak today. So we're going to move to another special circumstance, very much in hospital, management of cardiac arrest in pregnancy. And I hope that this will be a practical session for people who may come across this situation. So I'm going to move, I have no disclosures that are relevant to this lecture. There'll be some QR codes that I'll be showing, and you'll be able to scan those with your QR reader to open manuscripts that I might be referring to during the presentation. So the causes of maternal mortality have changed over the last few years, and we now see more maternal cardiac arrest from indirect causes. The majority cause currently is women with concurrent cardiac disease, and this is the latest UK report from the maternal mortality reports, and you can see that previous causes of death such as hemorrhage have really gone down in the frequency due to better care. And relatively cardiac disease has gone up because women are older, and women who previously would not manage to get pregnant are doing so. So this is UK data. This is the most recent French data that I'm showing here. And the slides on the left-hand side, you can see direct causes where hemorrhage in recent years has gone down, and other causes such as venous thromboembolism, amniotic fluid embolism remain important causes of maternal mortality. And if you look in the middle box, indirect causes, again, cardiovascular diseases is an important cause. And also in the United States, which has the dubious honor of being the developed country with the highest maternal mortality rate in the world. Hemorrhage and infection are important causes of maternal mortality. And in all of these reports, you may have noticed mental health conditions. This is women who are dying most likely postpartum, not while pregnant, so not relevant to our talk, but important to keep an eye out for these causes. I think this is probably one of the most important slides of this talk, and this is really why we're here, that 2/3 of deaths, it doesn't matter which maternal mortality report you look at, 2/3 of maternal deaths are considered preventable, and it doesn't really matter what the cause was. So we can really do a better job of identifying women who are going to die and preventing that from happening. So what we're going to talk about today is recognizing cardiac arrest in pregnant women, some of the guideline updates, and a focus at the end on simulation and education, basically taking these guidelines and turning them into something practical that you can do in your own center. So recognizing cardiac arrest, we need to know who are the women who are sick, who are the women who are going to become sick. And one of the ways that we can do this is using validated obstetric early warning scores. Many of these are available, and I hope that you have such scores implemented in your own hospital. And women who are at risk of morbidity and, of course, mortality should be managed in centres with the resources to care for them. And if they do arrive at a centre without the appropriate resources, then they probably should be transferred somewhere else within the abilities of your country or your setting, because this allows us to plan for potential bad outcomes, including maternal cardiac arrest and, of course, neonatal resuscitation, because when a cardiac arrest occurs in a pregnant woman, this is a disaster for 2 patients. So I've put here an example of a maternal early warning score with some of the parameters that we might be looking for that might become deranged, systolic blood pressure, heart rate, respiratory rate, and any derangement in these scores should cause an escalation in our care, referral to other teams, to consults, and to possibly transfer to a unit with better monitoring. And why is it important to do this? So the American Heart Association authors looked at 462 cases from their Get With the Guidelines data from 2002 until 2016, looking at the features of inpatient maternal cardiac arrest. And it's quite striking to notice that 2/3 of the women who had cardiac arrest had warning signs. 36% of the women had respiratory insufficiency, and 33% had hypotension or hypoperfusion. And by the time a cardiac arrest occurred, the presenting rhythm was for most cases a non-shockable rhythm. And although return of spontaneous circulation did occur in 74%, the rate of hospital discharge was low in this essentially, one would think, healthy adult population. Now, where are these cardiac arrests occurring? The majority, or more, in the delivery suite. This is also data from the Get With the Guidelines, but anywhere in the hospital a maternal cardiac arrest may occur, including the ICU, the operating room, and anywhere else where pregnant women may be being managed. And this is important if you're doing education and simulation to not just focus on the labour ward. So the same group of authors looked further, adding another year to their surveillance period, 561 cases, to look at what are the features of non-survival for inpatient maternal cardiac arrest. And 57% of women who had a cardiac arrest when pregnant did not survive until discharge. And important features of these women were pre-existing hypotension and hypoperfusion. So if we know about these women in advance, we may be able to offer them more superior care in a monitored environment to avoid that cardiac arrest is not an inevitable outcome. Arrest in a non-OR and a non-labour and delivery location were associated with not survival. So this is a lesson for us when educating our teams. And having an indeterminate presenting pulseless rhythm was also associated with non-survival. So how do we recognise a cardiac arrest? Well, any patient who is unresponsive, pulseless, we need to start CPR. But lessons from the NAP6, which I'll show you in a second, also showed that a weak, thready pulse with a low or unmeasurable blood pressure in a pregnant woman is an indication to start CPR. And I've shown here Nuala Lucas, who authored the Obstetric Anesthesia chapter of the National Audit Project, looking at anaphylaxis. And this lady was correctly identified as having an anaphylactic reaction following induction of general anesthesia. Anaphylaxis was immediately suspected. She was resuscitated, treated according to the guidelines. And the problem here with her care, looking back at the data, was that the team treating her could detect a pulse during resuscitation, although her blood pressure was unrecordable. And the trained healthcare staff decided that she had a pulse and did not start compression. So the lesson here is to start CPR early, even if you think you feel a weak pulse. This is unlikely to cause damage. So if we're educating and monitoring and identifying the women at risk, and we're recognizing who's under cardiac arrest and calling for help, of course, in the hospital system, which is hopefully 2222 for everybody, then we need to respond appropriately with the advanced life support algorithm. And this is not the place to go through this, but I'm sure all of you undergo training at frequent intervals to maintain your skills. But specific points from the ERC guidelines for maternal cardiac arrest. There is some evidence to suggest that the cardiac apex is slightly altered in pregnancy, but there is no recommendation to do anything different regarding chest compressions. So you must use the standard hand position for chest compressions with the standard rate of 100 to 120. Two important changes. One is to avoid aortocaval compression. Now, you may normally tilt women on their side if they are if they are not in cardiac arrest. But in cardiac arrest, in order to maintain effective cardiac compressions, we want to do manual uterine displacement. So the woman is still lying flat on the back, but her uterus is not pressing on the aorta. And this could be one or two-handed. And in our practice, this basically requires taking a team member, and that is their sole job, is to displace the uterus. Perimortem cesarean delivery should be considered and prepared for and initiated by 5 minutes, which in practice is 2 CPR cycles. Now, I'm going to come back to this comment in more detail in a moment, but we know that survival of women in cardiac arrest is increased if we can institute extracorporeal life support before a cardiac arrest happens. But the timing of this, of course, is very difficult to predict. But I just want to continue with some comments about perimortem cesarean delivery. We should be performing it within 5 minutes. And the main reason for this, obviously, it's nice that the baby might have a chance of survival, but the main reason for performing perimortem cesarean delivery is to empty the uterus and to alleviate aortocaval compression. And the patient should not be transferred. We found doing educational strategies that it's a very natural thing that people want to put the woman on the gurney and transfer her to the OR. This should not be happening. The perimortem cesarean delivery should be performed in situ where the collapse occurred. So we know that some of us may become more familiar during the COVID pandemic with these difficult decisions about instituting life support and getting the balance right about when to perform the cesarean delivery. So this is one algorithm. I'm sure many of you have instituted algorithms over the past 2 years to manage pregnant women who were disproportionately affected rather than their peers as healthy women when they were pregnant. So you have a critically ill COVID-19 patient, you've tried other strategies to improve her, and she's still hypoxic, and you're trying to decide whether to deliver her, whether to put her on ECMO. So around 32 weeks is the moment when you might decide to put her on ECMO. If she's not reached 32 weeks, you might decide to put her on ECMO. And if she's greater than 32 weeks, to consider a controlled delivery. But I think the important message from this algorithm is that if you find yourself saying, oh no, we can't do that, that will harm the baby, that is the wrong mind switch, and we need to get away from that, and we need to be thinking about the mother. So why might we want to do early delivery? Well, first of all, we can control the delivery and the time and place to avoid a perimortem cesarean, and we should consider that if the patient's deteriorating. Theoretically, we're decreasing the physiological demands of pregnancy, and we might limit the impact of pregnancy of that large uterus on intrathoracic pressures and volumes, especially if the woman's very sick. But we might want to delay delivery because we might be suspecting that we're not going to get a full gain of lung mechanics by doing an early delivery. And if we see that other strategies, for example, proning and ECMO, are improving things, and we might want to delay delivery. And we've seen this during COVID, that we might want to transport the patient if ECMO is what's needed and it's not available in our centre. So I wanted to show you here the maternal cardiac arrest algorithm from the Stanford Emergency Obstetric Anesthesia manual. It's not different from the ERC, but it's a nice booklet to have in your pocket for obstetric emergencies. And it just reminds us that there, in addition to the other causes of maternal cardiac arrest or any cardiac arrest such as the H's and T's, we can have anaphylaxis, hemorrhage, preeclampsia, cardiovascular disease, amniotic fluid embolism, a high spinal anesthesia. All of these can cause maternal cardiac arrest, and of course, last, local anesthetic systemic toxicity. And so our differential diagnosis for maternal cardiac arrest may be greater than the differential diagnosis that we're usually thinking of if a young woman undergoes cardiac arrest. So finally, a note about training. In addition to our annual training for the advanced cardiac life support, we need to be training our trainers and training anybody in the hospital who could have to manage pregnant women under cardiac arrest. And from our experience, we recommend simulation. we learned from simulation, for example, that when you're talking to the patient and then she collapses and she's no longer communicative, it's actually quite difficult to understand that she is now in cardiac arrest. And so that moment to identify when to start CPR is tricky, and it can be learned from simulation. I know I've mentioned that a dedicated person is needed for manual uterine displacement, but the cardiac arrest team are not used to designating a team member for this task. And again, this can be reinforced in simulation. And at any site where pregnant women may be treated, there should be a scalpel in the resuscitation cart, and she should not be transferred to the operating room if she's in cardiac arrest. So it's a lifelong learning cycle with simulation. So the incidence of maternal cardiac arrest, 1 to 20,000 or 1 in 12,000, depending on what data you look at. So it's not that common, but it probably will happen at some point if you're caring for pregnant women. Education, not just enough ACLS, but also simulation. 2/3 of maternal cardiac arrest do have preceding deterioration, and it's important to recognize an unresponsive patient and not to say, oh yeah, I think I can feel a pulse. Start CPR, it's unlikely to be problematic, and if the patient responds, then you can stop, and to call for help and to remember the manual uterine displacement and the perimortem cesarean delivery. Thank you very much, and I'll be happy to take questions during the session of questions afterwards.
Thank you, Professor Weniger, for the great talk on pregnancy-related cardiac arrest. Obviously, we can see why this is a special circumstance, and we will take the questions at the end of the next discussion. So, Dr. Thies, please introduce the next.
Thank you, Maria. Yeah, it's my great pleasure to introduce my colleague and friend Bernd Böttiger from Cologne University, the chairman of the Anesthetic University Department. He has got a massive track record on cardiac arrest research, which I'm not going to elaborate on. Bernd is telling us today about patient awareness and consciousness during CPR, which probably is a bit of an under-recognized problem, but those of us who have done cardiac arrest might have experienced this as well, and I have experienced this, and I must confess that I won't be forgetting these eyes, the looks of the patient who are panicking, looking at you when you are doing your chest compressions and you're trying to explain what you're doing. A difficult topic. Bernd, the floor is yours. Thank you very much. Are you still muted, maybe?
Sorry, the microphone was just driving away. Can you hear me now?
We can hear you very well, thank you.
Very good. So thank you very much, Carl, for this nice introduction, and everyone in this virtual room for listening to us today. I also really feel it's a difficult topic, and I will try to do my best to guide you through this topic over the next 15 or 20 minutes. And here are my, whoops, that was a little bit too fast. There's some delay. So here are my potential conflicts of interest, all related to any national or international activities in the area of emergency medicine or resuscitation. Until this morning, I thought we are virtual, but we also have some people in the room, but I just see there is no one in the room. So I cannot ask you who has own experience with this and ask for raising your hands. Carl already told us an experience that he had, and I had an experience which was similar to this. When I was 6 weeks after my university education working in a hospital, I have resuscitated a patient in the ICU following acute myocardial infarction. He was not ventilated, so he was spontaneously breathing, and he went into ventricular fibrillation, and I started cardiopulmonary resuscitation on him, and he was a very strong man. And after 2 or 3 minutes, as Carl just mentioned, he opened his eyes. He was totally afraid, and he was much stronger than me. And he put his hands and threw me away from his chest. And this was really a very, very strange experience to me. I stopped CPR, and less than 10 seconds later, he lost consciousness again, and I was able to proceed with CPR. So I had several of these kind of experiences, and already during these days, I thought, what will this do to the patient? And you probably know Nick and Kea. They have also been seen in the opening ceremony this morning. Kea resuscitated Nick when he was 12 years old. She was 16 years old, educated in CPR by the German Red Cross. And they did CPR on him for more than 10 minutes. And also experienced, as she told me, that they did such good CPR that his face changed from blue to red, and he opened his eyes. And then the young ladies, he did this resuscitation together with her friend, were really afraid, and they stopped CPR, and then he went into blue color and had already ventricular fibrillation again, and then they restarted CPR again. So this may also affect lay people when doing CPR. That's the important message coming here. And this story at the end ended very nicely because he survived. We had written a letter to the editor 2014 because we had seen a total recall and asked already the question, is it ethical not to sedate people during successful resuscitation? It was a 20-year-old female patient, 22nd week of pregnancy, cardiac arrest in pregnancy. After almost 1 hour of desperate resuscitation, unsuccessful conventional resuscitation, we discussed in the team whether we should put her on ECMO or stop resuscitation or proceed with conventional resuscitation. And at the end, we had put her on ECMO several years ago. And after 3-4 weeks after this event, her friend was an anesthesia nurse from my department. She reported to her exactly about what we discussed and what we have considered and how to proceed CPR. And her disability, she was just unable to intervene. That is really a strange experience everyone can probably imagine. And we ended up in asking ourselves whether, depending on the degree of cerebral depression that occurs as a consequence of reduced cerebral blood flow, different levels of consciousness may exist, including a fully awake state during cardiopulmonary resuscitation. We concluded that far-reaching implications for further behavior may emerge from our observation. The fact of possible consciousness during prolonged CPR, like the mandatory integration of sedative drugs into future algorithms, may be discussed and useful. And in the years to come, we have identified a lot of case reports and case series asking the need for sedation for a patient undergoing active compression, decompression CPR, and many others, even very old ones. I don't have the time to go into much details here, but it's interesting that it is increasingly recognized also in publications and in the literature. And we have identified a systematic review on the topic of consciousness during cardiopulmonary resuscitation, focusing on more than 2,000 reports and including at the end 9 studies. And the conclusion was CPR-induced consciousness was infrequently reported in the medical literature and varied in management. And given the increasing use of a mechanical CPR guideline to identify and manage consciousness during CPR are required. Then we have seen a CPR-induced consciousness topic, a cross-sectional study asking healthcare practitioners about their experience. So it's not only affecting the patients, but also, as pointed out in the beginning, the lay people and also the EMS personnel. More than 100 experienced healthcare professionals have been asked, and it is stated here that around 60% of them made the experience of consciousness during ongoing CPR, and most of them said, 70%, a guideline describing the management of this presentation was considered necessary by these responders. You are probably aware of the AWARE study, Awareness During Resuscitation. This was a prospective study published some few years ago in the journal Resuscitation. It's about the survivor's experience. And amongst more than 2,000 cardiac arrest events, I would only focus on the main conclusions here. Nearly half of the patients following out of hospital cardiac arrest had memories. 9% had so-called NDEs, which is near-death experiences, while 2% of these 2,000 describe real awareness. So that it is not very often, but it is 2% or maybe 9%, depending on the level of consciousness. The conclusion in the AWARE trial was survivors commonly experience the broad range of cognitive themes, with 2% exhibiting full awareness. That is the conclusion here. This, together with fearful experiences, may contribute to post-traumatic stress disorders following resuscitation due to cardiac arrest. And please remember the number, 2% exhibiting full awareness, and this is a prospective study in more than 2,000 patients. Another publication, a retrospective cross-sectional study of 188 sudden cardiac arrest survivors. And again, roughly in this study, it was reported that roughly 1/3 of sudden cardiac arrest survivors report clinically significant symptoms of post-traumatic stress disorders due to sudden cardiac arrest. Again, post-traumatic stress disorders, a study from the Netherlands. Main results, 1,630 patients initially resuscitated. 270 patients were discharged with good neurological outcome. 27% had a trauma score and fulfilled criteria for post-traumatic stress disorders. These patients had a significantly lower quality of life following out-of-hospital cardiac arrest. The only independent risk factor for the development of post-traumatic stress syndrome was younger age. They conclude a prevalence of PTSD in cardiac arrest survivors is high. Besides young age, neither clinical factor nor the use of sedation or analgesia were associated with the development. So there was no association with any other factors. Near-death experience in survivors of cardiac arrest, another study from the Netherlands. And I will skip the conclusion due to the time which is limited today. But as you can see here, no memory, 82% of the patients, some recollection, 6% of the patients, moderately deep near-death experience, 5%, deep near-death experience, 5%, and very deep near-death experience, another 2%. So awareness and near-death experience is really a very important issue during cardiac arrest and after cardiopulmonary resuscitation. And this was the reason why about 3 years ago, we have decided under the umbrella of the International Liaison Committee on Resuscitation to come up with a scoping review on CPR-related cognitive activity, consciousness, awareness, and recall. And you can see here the authors from that scoping review, which was very recently published, and I will show you soon the publication. We have analyzed a lot of studies, and I will go very fast through this because the most important studies I have already shown you. observational studies, review articles, a lot of case reports and case series. And we also found in the literature standard operating procedures where sedation during CPR was recommended in 4 places in the world with 4 different protocols: the Nebraska protocol, the Dutch Ambulance Service protocol, the Wellington Free Ambulance Service protocol, and in Australia, the Victoria Ambulance protocol. And all protocols were using ketamine, midazolam, fentanyl, and sometimes also a muscle relaxant, in this case rocuronium, as a suggestion for sedation during cardiopulmonary resuscitation. Unfortunately, this is only weak data. This is just recommendations. There are only very few studies. There are no standards, and we don't have any idea how this is affecting outcome with regard to survival, or outcome with regard to the level of consciousness or the level of post-traumatic stress disorders. This is the publication, just appeared a few weeks ago in Resuscitation Plus, CPR-related cognitive activity, consciousness, awareness, and recall, and its management. As already stated, this is a scoping review. You can see here again, in the meantime, we have found more than 3,000 articles, and records included in this review was 40. The conclusions are very vague, and that is what we can say today, and I will summarize it in the next 2 slides, even a little bit more to the point, but I would like to read for all of us the conclusions very slowly. CPR-related cognitive activity, consciousness, awareness, and recall is uncommon, but increasingly reported by professional rescuers. And by the way, it's not only affecting the patients, but also the rescuers, regardless whether these rescuers are lay rescuers or professional EMS personnel. The data available was heterogeneous in nature and not suitable for progression to a systematic review process. That's the reason why it was a narrative review. Although local treatment protocols, I have shown them to you, exist for management of CPR-induced consciousness, there are no widely accepted treatment guidelines. In settings in which it is feasible, rescuers may consider using sedative or analgesic drugs doses to prevent pain and distress to patients who are conscious during CPR. And we are doing this in prolonged CPR situations where we feel that we are doing very good CPR. And the conclusion, last sentence, is more studies are required to investigate the management of CPR-induced consciousness. And to bring it a little bit better to the point, we can probably summarize it's seldom, but remember it's 2% at least, and maybe near-death experience in 9%, increasing number of reports, more often in witnessed arrest, lay CPR. So if you start CPR very early, before the EMS is arriving, in young victims, and with the use of mechanical CPR systems. It is stress and maybe post-traumatic stress disorder for patients and for personnel, and we don't know so much about prophylaxis or therapy. My conclusions for today are, it's a relevant problem. Please think about and consider. Risk factors, again, good CPR. So it's obviously a good sign if the patient is opening the eyes, but at least then you should probably use something to sedate her or him. Lay CPR and young victims, we do not have clear concepts yet. Maybe we will never have clear concepts for this kind of an event. We should decide on sedation, that is my suggestion, individually. Few standard operating procedures are available, and very important, be aware during the resuscitation that the patients may remember what you are saying hours, weeks, or months after the CPR if they survive. So be aware to communicate in a positive way, and always take into consideration that the patient will remember what you have communicated in the team during ongoing CPR. And maybe another aspect with a question mark, maybe we should investigate our patients following successful CPR for these kind of experiences and for post-traumatic stress disorders. And maybe at least some of them would benefit from a trauma therapy after cardiopulmonary resuscitation.
It only takes 2 hands to save a life.
And don't forget, this is the most important message.
It only takes 2 hands to save a life.
Coming from Brazil, where we have trained a lot of school children in cardiopulmonary resuscitation. So thank you very much for your attention today in this special setting. Thanks.
Thanks for your great talk, Bernd. This is a raising our awareness towards awareness during cardiac arrest. I think there are publications on this topic, but it is still not quite in the focus of the interest, I think. Are there any questions from the floor regarding this particular topic?
No questions from the floor, but because Dr. Bettinger would like to ask his question about experience, I created a poll, and the results about who had experience with awareness was actually 57% of the ones who vote actually had experience with patients that had awareness during cardiac arrest.
Thank you very much. Great action. This fits very well to the data I have shown you from the literature. By the way, do we know how many people are listening to us currently?
I'm not sure, but I can see here we had 13 votes. Not very big, actually, but yeah, the results fit your presentation.
Thank you very much.
Hey, and then, of course, the question is, you've raised a few points, and given the gravity of the side effects, shouldn't we really considering sedating these patients standard, or do we know anything about the effects of sedation on the outcome of cardiac arrest? Maybe would that be a problem?
There is one study that I remember that have investigated, but not in a systematic randomized controlled way, but just in a descriptive way, and compared two groups of patients. One has received sedation and the others not. And there was no significant difference with regard to the survival outcomes. I don't remember any study focusing on awareness outcomes comparing sedation versus no sedation. So there is really a field for further research. And I agree with you and maybe with many of us who have made these kind of experiences that this is really a very important issue for research and for careful patient management in the future, I would say. And it does not only include sedation during prolonged CPR in cases where you have young people, immediate start of CPR by lay responders or mechanical CPR devices. But this is one thing. But the other thing is that many patients have not only awareness experiences, but also post-traumatic stress syndrome, which is probably not full awareness, but something is getting to the brain in these patients and affecting them mentally in the post-resuscitation period. And at least in patients who are surviving a cardiac arrest, we should investigate this much more carefully and systematically than we have done before in the past.
Yes, I think that is an important aspect, and we might also not forget the communication that we have with such patients. This may be the last experience that they have in their lives, and that is something which we probably haven't thought through very well at this stage, and a topic that we need to focus on. Thanks for raising this topic. It's really important, I think, really important, and probably a bit undervalued.
And please, if you're interested in this, read the publication in Resuscitation Plus, which is an online journal, so it is very nicely accessible to everyone. It's probably worth to have a closer look on this.
Thanks, Bill.
Thank you so much, Professor Bittinger. We have some more questions regarding the other talks. One is addressed to Professor Weniger, which and it's asking why our mechanical chest compressions are not recommended in the pregnant patient.
From my understanding, it's due to the trickiness of positioning them appropriately with the pregnant belly, and that it's technically easier to use two hands to do that, especially if you're concerned about the uterine contents, the baby being damaged.
Are there any results on the outcome when mechanical chest compressions were used in these circumstances?
So I have never used mechanical devices at all. They are used in my knowledge as a bridging device or for the paramedics. So I don't feel qualified to answer that question. Maybe one of my colleagues wants to step in.
I must say my experience doesn't reach to a regular treatment of cardiac arrest in pregnant women, and I don't feel really competent to comment on this. So we know that chest compression devices have the tendency to cause more injuries than manual chest compression. So that probably could be a reason not to recommend it, but I think it's not properly investigated, in fact. So there's certainly space for some investigations as well. But these patients should be moved anyway. So as you said, as you told us, so they should be receiving the perimortem sections where they are. This is what you're recommending. Yeah? Mm-hmm.
Yeah.
And I also created a poll about that, about people who had experience with perimortem C-section. Not too many answers again, but the results show that not too many people have actually experience with that. 75% of those who answered never had experience with perimortem C-section. So I guess more training is needed.
So I would thank you for creating that poll. Among the people who haven't managed it, the data suggests it's not very common, maternal cardiac arrest, but when it does happen, it's going to be a surprise, and you want to make sure that you're going to be best equipped to deal with it. So take the opportunity to train, simulate, educate the team, because that one case that might happen in your entire career is the case that you're going to want to manage as brilliantly and as perfectly as possible.
There's now a question from my side. I mean, this is obviously, I think, a massive human factor issue, isn't it? To come to the decision, oh, we got to do that. Where's the knife? How do you do this in practice? How do you train this? I mean, how did you train this in a district general? Could you give us advice on this, how to take this forward?
First of all, everyone has to be on board that the concept of perimortem cesarean delivery is to save the mum's life. Hopefully the baby as well, but that's not the reason that we're doing it. And I can just tell you from our experience, you take the textbook and you take the guidelines, and it's written very clearly that within 5 minutes you want a perimortem cesarean delivery. But in order to bring that into practice, first of all, you need to have the scalpel available easily. So any place where a pregnant woman may undergo cardiac arrest in your hospital, there has to be a scalpel inside the resuscitation cart. And that's a message that came out very clearly from the United Kingdom surveillance surveys, because if you don't have a scalpel readily available, there's going to be a delay just running to the operating room to get hold of it, right? And then conceptually, everybody has to be on board that as soon as you've diagnosed the cardiac arrest and as soon as you started CPR, in practice, when we were doing these simulations, we understood that this is basically 2 cycles of full ACLS CPR. It's counting that each cycle is 2 minutes and that you've possibly delayed making the diagnosis, that and you obviously somebody should be keeping time. That person who's keeping time after 2 cycles should be telling the experienced person, the obstetrician, to perform a perimortem cesarean delivery. And the recommendation is not a low transverse cesarean incision, it's a longitudinal incision. Probably not going to be much bleeding, because don't forget the patient is in cardiac arrest.
You're not doing the right thing, yeah.
From people, no, I can't do such a big incision because she's going to die of bleeding. Well, she's actually, you know, and we would try to carry on doing the CPR at the same time, but if you need to stop for those seconds while the incision and the uterus is being evacuated. And then the other thing, of course, to remember is that you have to put the baby somewhere. So if you are in a cardiac arrest situation, you have to call the neonatal team, because you don't want to be focused on this now living being that you've pulled out of the mother's uterus. Somebody else has to deal with that baby. So there's a lot of people to train and call. I hope that answered some of your questions. For us, the main issue was getting the scalpel in the cart, because the gynecologists were very focused on, yes, we've read the guidelines, but we prefer to do our cesarean deliveries in the operating room, and we want to transfer mum. And we really had to change that mindset. So I suggest that it's not enough to have the guidelines. You should run simulations in your own center so that you pick up what the pitfalls are going to be, because what happened with us is not necessarily what's going to happen with you, but you want to have a good experience if it's going to happen.
Oh my God, this is scary stuff, I must say, from my point of view. Is it all you need is a knife? Is that all the rest is done with your hands, or a?
So a scalpel to open the skin, to open the uterus, a pack of gauze swabs if there will be some bleeding, and a clip for the umbilical cord.
Yeah. Okay.
That's what you need. And there are resources in the ERC and also the American College of Obstetric and Gynecology guidelines of the kit that you need. But if you don't have anything available and you just need to do the cesarean, you just need a scalpel.
Okay, thanks for your advice. I'll have a talk to our obstetricians tomorrow, see how we're prepared for dealing with this. Thanks, Carolyn. Have you got further questions, Maria, coming in?
I have some questions. Do we still have time to ask? They are addressed actually to our last speaker, Professor Bettinger. One is actually asking, is interesting, if capnography would be one of the signs of awareness. Could we use the capnography to guide us?
Yeah, thank you very much for this question. I cannot give you an answer based on any publication, so I'm not aware of any publication focusing on that issue. But since capnography, or a special level of exhaled CO2 made visible by capnography, is a sign for good CPR. And what we know from the literature is that good CPR, so if you really press hard and fast, and what we are all teaching here in Antwerp and around the world, if you have good CPR, the chance of getting awareness and all these other not so nice things is much higher than if you are doing very not so good CPR. That's clear. So there will probably be a correlation with capnography if we would investigate this, but it's not investigated yet. So, but the aim is always to make CPR as good as possible, to have high CO2 levels during ongoing CPR, But the downside is you will also then have higher rates of awareness and maybe post-traumatic stress disorders. But you can only have awareness, be aware of this, if you are alive.
Thank you, Professor Bettinger. I think the time is up.
May I ask one last question?
Of course.
Thank you.
I think because we've started a little bit later,
we should
can
have
get ourselves a little bit more time.
We should be allowed to bit of overrun. Viviana, your talk, obviously, or your topic, is probably one of the most life-saving topics, and the whole concept of cardiac arrest treatment and resuscitation. And we've only seen the survival rates going up since we have started focusing on lay resuscitation and on first responders. So my experience is, and what we know from preliminary research, that the quality of lay responder resuscitation is not always so good. How are we going to tackle this? What is your experience? How are we going to deal with it? How can we make this better and save more lives?
So I think there will be several approaches. One is that we really have to teach more people and to continuously teach them. It's not just okay to teach them once in their lifetimes. They have to be taught like school kids every 2 years. So ideally, we would teach every adult like every 5 years or something like that, so that they are continuously addressing this topic. And another thing is the telephone CPR. The dispatcher has a huge possibility and opportunity to focus on compression frequency and continuously saying, press harder, press deeper. And I think with the upcoming video telephone CPR, the dispatcher will be able to see what is really done at the emergency side. So maybe the bystander is just telling the dispatcher, yeah, I'm doing it all. And in reality, he's in another room. So we all heard stories like that. So with the upcoming video CPR and the combination of continuously training more people, I hope things might get better.
Thank you. Do you think it's still a big field for research in the very near future?
Yes, I think so, because we are aiming to train every person globally. So we also have to focus on different people. So that's one thing is a cultural thing. Do we train people in high-income countries the same way as we treat them in low or middle-income countries? Is there a difference between cultural backgrounds? But also, do we train elderly people in the correct way? And elderly people are the ones that most likely will encounter their spouses having a cardiac arrest. So actually, we're coming up with a study on this one. We're on the preparing part, but we are really interested in how can we teach elder people to perform CPR.
Great, interesting, very, very, very interesting. Thank you so much, Maria. Bernd, just still, yeah.
Yeah, thank you very much. I just would like to underline what Bibiana just said, and Bibiana showed to us the big 5 in cardiopulmonary resuscitation, and these are the fields where we should work on. And one of the big 5 is school children education in CPR, so Kids Save Lives. So please help us to establish Kids Save Lives programs all over the world. It is recommended by the World Health Organization since 2015. And the other thing is the World Restart a Heart Day, also mentioned by Bibiana. It's every year on October 16, and since this is a session together with the European Society of Anesthesiology and Intensive Care, it is probably adequate to say that October 16 is also the World Anesthesia Day. So anesthesiologists all around the world can combine these 2 days. And the next October 16 is this year on October 16. And please help us to do as much as possible publicity for lay CPR on October 16, World Anesthesia and World Restart a Heart Day, or in the weeks before and after. And that will help us to make the world an even better one.
Okay, so we obviously have to join forces from the ERC side and from the ESAIC side as well. Maria, do you want to close?
Sure. thank you all very much for listening to us. I hope you enjoyed the talks of our great speakers. And Professor Bettinger made a great point that future collaborations with ESAIC and ERC would be great to promote the Two Hands Save a Life initiative and the World Restart a Heart Day. So I hope more of these webinars and congresses will come up. Thank you very much to the speakers again, and I hope to see you all live soon. Okay.
Thanks, everybody.
Thank you very much.
Okay, bye-bye.
Bye-bye.
Bye.
Thanks. Bye-bye.
Thank
All the
you.
best.